Hi, and welcome to another episode of Enter the Vault. We are still dealing with technical difficulties, as so far I am not hearing any sounds, so fingers crossed this is going to work. Today we are going to dive into the history of HMOs, PPOs, as well as DPC. As I mentioned last time, our industry is a absolute soup bowl of acronyms, and we tend to use acronyms for almost everything. So I am going to explain exactly what each of those means and give you more information. So let's see if I can get some sound, because that would be really nice. Well, I am only listening to myself, so I guess that is going to work for now. So I feel like I'm really a good person to talk about this subject, because a lot of the foundation of some of the innovations in how healthcare is financed and paid for today actually happened in Washington State, which, as you know or may not know, is where I'm located. So let's start with HMOs. It stands for Health Maintenance Organization. And they were actually developed in the 1930s by Henry Kaiser, who was an industrialist, and he partnered with a Dr. Sidney Garfield. Okay, we're gonna have to bring the glasses out for this one, because clearly I can't see what I'm doing. So let me, again, I've got so many different things going on here. Hopefully we can see what we're doing. So he partnered with a Dr. Stanley Garfield, and they created a prepaid health plan for workers at the Grand Coulee Dam, which is a hydropowered dam here in Washington State. And the emphasis was on preventive care and designed to be affordable. Notice the key word, affordable. Well, it continued that way for a number of years until 1945, and that's when Kaiser opened its doors to the general public. And they became the model and basically the template for HMOs, which rose to great popularity in the 1970s, primarily due to rising healthcare costs. Sound familiar? In 1973, the HMO Act of 1973, clever name, was passed, and it required employers with 25 or more employees to offer a federally qualified HMO option if it was available or if it was requested by employees. But again, that only applied to employers with 25 or more employees. So what exactly is an HMO, and what are the primary qualities that define it? So an HMO in general is a closed network. In most cases, the doctors are employed by the HMO themselves. So in other words, they're not out in your community, and unless you're a member of that health plan, you are not going to see those providers. They often own their own hospitals, or if they don't, they rent an entire floor or wing of a hospital, and then that is the, for example, Kaiser wing. They require members to choose a primary care physician, and then all of the care is managed and coordinated through that provider. They need to get a referral before they can see a specialist, so they can't just decide, oh, hey, I've got a spot on my shoulder, I need to go see a dermatologist. That actually needs to be coordinated through your primary care provider. There's also no coverage outside of the closed system, except, of course, in the case of emergencies. So if you just arbitrarily decided, okay, let's use this same example of spot on my shoulder. I heard about a really good dermatologist that my friend uses, and I want to go see that person, and he's not I'm not picking on Kaiser, I'm just using it because we talked about it. He's not a Kaiser doctor. There will be no coverage for that at all. You would have to pay that 100% out of your pocket. There was always a strong emphasis on preventive care and cost control. So the original idea of HMO plans was that they were going to be less expensive because of their focus on preventive care would then alleviate the need for more intensive care down the road, emergency room trips, visits to specialists, etc. Interestingly enough, in my state, in Washington State, where Kaiser is actually a force factor, HMOs can be more expensive because just of how their model is put together. So we'll talk about that a little bit more as we work our way through here. But let's talk about what a PPO is. So that stands for Preferred Provider Organization. Almost every one of you listening to this has a PPO plan. You have a logo on your ID card that tells you what network of doctors you're going to utilize. One of the very first ones was developed in 1980 in Denver, and it was developed specifically for employers in Taft-Hartley trusts. Again, they were looking to bring down the cost of care, and the idea was that they would be able to offer more affordable options compared to traditional indemnity plans or even HMOs by negotiating discounted fees with providers and implementing utilization review. Utilization review, pre-authorization, it is our nemesis of many health plans. We've all dealt with it from time to time. That is just something we'll be doing a deeper dive into a little bit later in this series. But those are some of the key components that they felt, that insurance companies felt, would drive to lower costs. So what are the key components of a PPO? Open networks. So they do have a list. Used to be a book. You used to get a book with a list of all the doctors you could see. Now those lists are online because they change all the time. And the providers are not employed by the health plan. So in other words, they're employed by their healthcare system, their independent practices, et cetera. And the health plan contracts with them to accept a discounted fee off of their, we'll call it their shelf rates. So discounted off of what? So again, we'll go into that a little bit more. Most plans do not have a primary care provider requirement, so you don't need to have a PCP to give you referrals to go see specialists. And most preferred provider plans also include coverage for out-of-network services. So that example I gave you earlier of wanting to go see a specific dermatologist for my shoulder, under a PPO plan, if that doctor was out of network, there would be coverage for it, but it would be at a much lower rate than if I saw a in-network provider. Oh, I have a great comment here I want to pop up on here. I remember handing out paper provider directories. Thank you for raising the bar on industry knowledge. Well, I appreciate that. I too remember handing out paper directories, and they were thick. They were like this big, and everybody wanted one for themselves. So I have to say, I'm actually a fan of the online directories. It's really nice. But that is really where the PPOs got their start. And I can remember, again, this would have been in the late 80s, I want to say, sitting in a boardroom of a local healthcare plan in my area, and they were going to roll out their first PPO plan. And they were so excited about it because it was going to be this network, and it was going to be so much easier for members to use their healthcare insurance. And all they were going to have to do was show their card and pay $5 or sometimes $0, and they were going to walk away with all the care in the world they needed. Well, the problem is that did not encourage wise decisions on either the providers or the members' part. So the PPO system, although it is still the vast majority of what we have today, in my opinion, is somewhat of a failure. And part of the reason that it is a failure is because the discounts are off of fictitious prices. I don't know if any of you have ever been to, this used to be a popular thing as well, showing my age. I can remember there were stores that had displays of gold jewelry on display, and they were always on sale for 50% off. Now, if you were always on sale for 50% off, was that original price even a legitimate price, or was it just something to make you feel like you were getting a good deal? I honestly think that the same thing happens with PPO plans. We have these outrageous numbers that then can be discounted down to a level the provider feels is acceptable, and the health plan thinks, wow, I've got a 40% discount, I'm getting a good deal. And the member thinks, wow, I'm getting a 40% discount, I'm getting a good deal. But what if we just paid the fair price? What if we skipped all of that baloney and we had a determination of what fair pricing was, and that's what providers charged, and that's what members knew they were going to pay? Think how much easier that would be. So now we're going to get into a little bit of something different, and that is the DPC model. That stands for direct primary care. And again, this movement really has its roots in Washington State with Q Liance. So Q Liance was founded in Seattle in 2007 by two pioneering doctors who wanted to provide membership-based direct primary care. So patients or employers paid a flat monthly fee to the doctor's office for comprehensive primary care services, cutting insurance out of the equation. So there was no insurance in this particular situation. So for an example, let's say that I had a direct primary care, and direct primary care is gaining a lot of popularity again. So I'm a fan of it, but I want you to understand it. Let's say I pay $100 a month to my direct primary care doctor. In exchange for that, I am supposed to have longer visits, a big emphasis on preventive care, and unlimited access to my doctors. So I should be able to call them up, email them, text them, get through to somebody in a reasonable amount of time, and have that care that I think we're all craving. For many of us, we grew up with a family doctor who knew us, who, if he ran into us or she ran into us at the grocery store, actually knew our names. I would say for the last 20 years, my doctors have no idea who I am. I know I do have a hybrid doctor who's semi-DPC, so he actually does know who I am, and if I ran into him on the street, he would know who I am. But that's the actual exception to the rule, and it doesn't quite seem right. So Q Liance claimed that it was able to handle approximately 90% of typical patient needs without the need for additional outside services. Now, to be clear, Q Liance was actually a clinic model. So you would choose a clinic that would be your primary care place of care. And there was a number of doctors, nurse practitioners, assistants, et cetera, in that practice. So it wasn't just one doctor. They were saving approximately 20% in healthcare costs by reducing visits to the ER, specialist care, and inpatient stays. Despite their early success, they closed their doors in 2017 due to financial struggles. Q Liance had over 33,000 members at that time when they closed. And one of the primary reasons, other than the financial struggles, because there was some shady goings on behind the scenes, Dr. Erica Bliss says, the healthcare system is hostile to change. I could not agree more with that statement. And this is nearly 10 years later, it certainly is not any friendlier. So the one thing all of these models have in common is some sort of financial incentive that sometimes benefits the patient and sometimes does not. So DPC, the direct primary care model, is currently gaining a lot of momentum due to exactly what it is supposed to do. It's supposed to lower costs, supposed to. I'll work on my grammar and my enunciation, and more personalized healthcare. The reality is it's a capitated model and money is a strong motivator. So what do I mean by capitated model? You're paying a membership fee of $100 a month. How many patients can you handle at $100 a month and give them that unlimited access and that personalized healthcare that you promised? Is it 100? Is it 500? Or is it 1,000? And if you have 1,000 patients on your books at $100 a month, how are you giving them that personalized healthcare experience? How much can you grow your practice without sacrificing care? So there was a form of HMOs in the 80s, 90s, somewhere in there, even into the 2000s. Sometimes they were called ACOs, Accountable Care Organizations, or EPOs, Exclusive Provider Organizations. It's just fancy ways of saying the same thing. But doctors or healthcare systems were giving a certain amount of money each month to manage that member. The only way they made money was by providing less care. Bottom line. The story was that the way they made money was by providing better outcomes, which sounds better, and I believe was truly the ideal. But there was always a misaligned incentive there because the patient's best interests were not always aligned with the provider's best interests. Because if there's that push-pull between what's good for me as a doctor and what's good for my patient, human nature often wins. So I think it's really important as we explore these and we continue to advocate for direct primary care that we're careful about how we do it and we think about how to do it in a sustainable way that's good for the doctors, because believe me, I am not throwing any stones at the doctors here. There are too few of them, and they are overworked, and they want to have that experience. They want to have that personal one-on-one experience, which is why they're leaving the traditional system of insurance, where an insurance company is telling them whether a test is okay to order or not, whether a procedure is okay or not. But please keep in mind, even direct primary care, not all of your care is going to be provided within that system, because unless they have online, a full online lab and x-rays and diagnostic equipment, and many of them don't, you're going to be paying for that either out of pocket or through other insurance. If you need a surgery, the same thing is going to apply. So while it's a admirable idea and one I hope that we can figure out, there's still some concerns there. Because if we're paying $100 here a month for the direct primary care and we're paying $600 a month for a high deductible catastrophic plan to protect us for all the other things, it's still expensive, still unaffordable for very many, many people. So this kind of outlines and lays the foundation for where we will go from here. So on our next episode, we're going to dive into utilization management and prior authorizations, because that is the linchpin of how many insurance companies are controlling costs and access to care, and also the barrier to care for many patients. So I hope you enjoyed this lesson on the history of our industry, covering PPOs, HMOs, and DPCs. We will be diving more into the DPC model later in this series because, as I mentioned, it is definitely gaining traction and it is something I believe in. So I want to discuss how the most successful DPCs are combating the challenges that I mentioned. If you have questions or ideas for an episode you'd like me to dive into, please drop it in the comments or send me a direct message. Until next time, it was great spending time with you in the vault.